This will please now come to order. Would you please call the roll?
Alderwoman Flowers, Alderman Vollmer, Alderwoman Davis, present. Alderman Arnowitz,
here.
Alderwoman Hubbard, Alderman Carter,
Present.
Chairman Schmid.
Here. Thank you very much.
Present.
Thank you. Alderman Arnowitz, would you please start with Board Bill 141?
Thank you. Thank you, Mr. Chairman and members of the committee. Before you today with Board Bill number 141. And what this does is Mid America Transplant is entering into an agreement for a grant with the Medical Examiner's Office for the amount of $25,000 each calendar year until they decide not to fund the extra. But what this does essentially is it helps the Medical Examiner's Office to be able to use this money for things, you know, upgrading the computer system, which helps with the investigations over there. Could use the money for infrastructure and different things, along with helping the investigators. Because they've had such a good working partnership, and this is the reason that they want to do it. So I'm asking your consideration for the approval on this board bill today.
Thank you. I think Mr. Baxter Leisure is here as well, if he could come up and add to that. Thank you.
Yes, my name is Baxter Leisure. I'm the Executive Assistant to the Chief Medical Examiner, Dr. Michael Graham. Fortunately, Dr. Graham couldn't be here this morning. He had to attend a deposition, so I'm here in his place.
So I'm sure you'd rather be at the deposition than
No, not at all. I'm glad to be here, and pleased to answer any questions you may have relative to the board bill in the operation of the Medical Examiner's Office.
Oh, that's it? Okay. Are there any questions from the committee? Okay. I told Mr. Leisure that I had some questions that were related to the office, so I'll go through some of those questions at this time. Can you tell us, sir, what are some of the procedures for providing respect by screening, shielding, or covering a body of a dead loved one on a crime scene, and whether those procedures are in writing?
Well, basically, this is a question that should be answered by our EMS and homicide division. As medical examiners, we are not literally first responders at a scene, so many times the shielding of the body has already been in place when we arrive. But again, that's something that I think would be better answered by our EMS folks and especially by the homicide division.
So is it your experience when you get there that the body is or isn't shielded? Can you tell us that? Routinely,
it is shielded. Usually it's covered. Okay. And those things are done immediately upon the expiration or the declaration of someone being pronounced lifeless.
So it's your understanding that the police and EMTs do have that equipment available to them?
Yes, that is correct.
Okay. Is there any provision that your office has for how much time it takes for a dead body, to be removed from a crime scene?
No, I mean, obviously we want a body removed as quickly as possible from the scene, but there's a lot of variables at play that may affect the timeliness of that removal of the body off of a scene. Typically, we're not going to go into an unsafe area or an unsafe scene. So that being the case, then obviously the body would rest there until it is safe to effectively remove the body off of the scene or out of the scene.
So then when you arrive at the scene, you have to work then with the police investigation, or at least, well, tell me what happens if you arrive.
Well, typically you have to understand the scene itself. The scene literally belongs to the police department. We're the guests of the police department while at that scene. So we try not to contaminate their scene. Likewise, we don't want them to contaminate our body. Because literally at the point of time that we accept that case as a medical examiner case, that body belongs to the medical examiner to preserve it. It is obviously a piece of evidence. So it's incumbent upon us to protect that body as best we can.
So I thank you very much. I know you were here just on Board Bill 141, but I thought as long as you were here, we had some testimony from the chief relating to the police procedures. There may be some more discussion about that, but I thought it might be helpful.
To speak to you and hopefully the board will approve.
Great.
Thank you.
Thank you very much.
You're welcome.
Is there any more testimony with regard to Board Bill 141? Alderman Arnowitz, are you ready to close?
Yes, thank you, Mr. Chairman and members of the committee. Again, I think this is really great that Mid America Transplant working with the medical examiner's office and helping them keep things upgraded as we move on. So at this time, I'd ask for your considerable approval on this board bill.
Thank you very much, Alderman. And I also applaud the medical examiner's office. Obviously, it's always helpful if we can get private industry to help with some of these issues as well. Is there a motion on Board Bill 141? There's a motion to pass Board Bill 141 out of committee with a due pass recommendation. It's been seconded. Would you please call the roll?
Alderwoman Flowers.
Aye.
Alderman Vollmer. Alderwoman Davis.
Aye.
Alderman Arnowitz.
Aye.
Alderwoman Hubbard. Alderman Carter.
Aye.
Chairman Schmid.
Aye.
5 aye votes do pass.
Thank you all, and thank you, Mr. Leisure. I appreciate you hanging around a little longer to help explain some of those items very much. Thank you. All right, so Board Bill 164, if you will indulge me, I'll just be here and ask, I believe, if our Director, Pam Walker, could please come up. I believe this is on the Equitable Relief from Utility Tax Fund, and that's heat up and cool down.
Yes. This is a funding authority issue. The money in this fund comes from taxes collected on utility bills that are paid for by LAHEAP, State Utility Assistance, AMR, and Laclede. I think the ordinance was passed a long time ago, maybe 15 years ago, so that we didn't tax donated funds. So it's sort of like a double tax. So it goes into this fund. It's really hard to predict because it depends on the weather, the funding levels at the federal and state level, and when those come in and when those are paid. So our budget authority was for $125,000. We have a contract in place with Heat Up St. Louis for $125,000. We got a huge deposit of about $100,000 in June. So we couldn't get it out last year, so it's a carryover cash flow. So we've already given the money out, $125,000 out. We've already met the contract amount. We're going to be collecting funds, I think, for the rest of the year. So I'm just asking that the spending authority lid be lifted so that as we collect monies, they're not sitting there while people need them, and I can increase the contract and get the money out faster. So does that make sense?
All right,
Okay.
so there's no amounts that will be given out if they're not already in the account, is what you're saying?
Yeah, it's a earmarked account. It's not general revenue. It's not use tax. It's can't be spent for anything else.
And that's in Section 2, I believe, that limitation. Are there any questions from the committee? All right, so I'll entertain a motion on Board Bill 164. There's been a motion and a second to pass Board Bill 164 out of committee with a due pass recommendation. Is there any objection to previous roll? Hearing no objection to previous roll, Board Bill 164 comes out with a due pass recommendation. Board Bill 165, again, I believe that Mr. Sikora has this. It's a grant application on a Continuum care grant for, I believe, homeless. Is this yours?
It's the homeless. I have no comment on that.
Okay, do we have anyone here from Human Services? Okay. So my understanding is that this is in the amount of $121,207. They've attached the exhibit which explains the scope of work on this. Let me see what that is. Well, they're not here, so I'm just going to hold this. Board Bill 166, is on the grant award from Missouri Alliance Area Agencies on Aging for the Navigator Project Services. Mr. Sikora, thank you.
Good morning, thank you. The Centers for Medicare and Medicaid Services approved funding to the state Missouri Association of Area Agencies on Aging to promote the Navigator services of the federally run healthcare marketplace. The enrollment period for the ACA is November 15th of this year. On September 18th, as a member of the State Association, SLAY, which is part of the Department of Human Services, was awarded $64,971 to provide navigator services in the city of St. Louis. Those services include public education, one-on-one counseling, and one-on-one enrollment assistance. And so what we're asking for in the board bill is permission to expend the funds and contract with our partner agencies to perform those services.
Are there any questions from the committee on Board Bill 166? Hearing none, I'll entertain a motion on Board Bill 166.
So moved.
Second.
There's been a motion and a second to pass out Board Bill 166 with a due pass recommendation. Is there any objection to previous roll? Without any objection, it comes out of committee with a due pass recommendation. Thank you so much.
Thank you very much.
I'm looking at this Board Bill 165, which I saw before, and I know that they want to try to get this out so that they can expend these great monies that they have. I asked them, and they have attached the information from the U.S. Department of Housing and Urban Development for how they're going to use these funds. And basically, it's all for planning costs on the continuum of care. Are there any questions on Board Bill 165? If there's no questions, I'll entertain a motion on Board Bill 165.
So moved.
Any objection to previous roll? Without objection, it comes, Board Bill 165 comes out of committee with a due pass recommendation. We also have a couple of presentations. I leave it up to you. Would you like to do the Ebola presentation?
Try to be the shortest.
Yeah, it's a shorter one. Thank you. And then following that, I thought it would be helpful for us to know about the Healthy Eating, Active Living partnership that's going on, because we hear some about that.
Do you have another copy of that?
Oh, yes, yes, we do. Sorry about that. Thank you.
Okay, good morning. Thank you. I'm the St. Louis City Health Director, Pam Walker. Wanted to give you a brief update of what we're doing to prepare for Ebola in the city and in the region. You know, there's really three issues around Ebola. One is what's going on in Africa. One is what's going on back home in our country. And then three, what are we doing locally to prepare? And what I've given you is a summary of all the work we've done in the last couple of weeks to prepare. This is, from the African standpoint, this is probably the greatest public health threat since the last 100 years. It's not under control. It is expanding exponentially. We've gone from a few cases in March to 8,000 documented cases in Sierra Leone, Liberia, and Ghana. And the projections, if we don't get it under control, are as many as 10,000 new cases a week by the end of January. The federal government has mobilized troops. There's a lot of people like Microsoft putting money into this, but they can't build things fast enough. In Liberia, by the end of December, they'll have 4,500 beds, but we're looking at 10,000 cases a week. So it's really got a lot of us in the public health field very, very concerned. And the people that are going over there to try to stop the epidemic where it is are really, risking their lives to save ours. and we owe them medical treatment at home. We owe them our support, because the smartest thing to do is to try to stop it there. The human suffering is horrible. The economic instability is frightening on top of everything else. And there are a lot of reasons why it's spreading like that in Africa. A lot of it is cultural, a lot of it is poverty. You know, they have one refugee camp in Liberia that has 50,000 people in it. They look at hospital treatment differently. You go to the hospital to die there. You don't go to the hospital to get well. So when people come and take their family member away and say we're taking them to the hospital and they never see them again, they start trying to hide their patients and start trying to hide the fact that they've even got anyone sick. So we really think that it's grossly underreported. And the current mortality rate was at 50%, and it was based on cases that they could actually follow from beginning to end. They've now got an estimate that the true mortality rate's about 70%. The other cultural issue is they take care of their sick family members, so they bathe them, they wash them, they change their clothes, and also when they die, they bathe the body and bury the body themselves. So there's lots and lots and lots of potential for exposure. Luckily, this is not airborne. If it was, we'd be in serious trouble, and it would have spread much more rapidly. It spreads more slowly than something like MERS or flu, but it's much more deadly, and that's what we're looking at. You can't get it from people coughing, sneezing, droplets. You have to have direct contact with someone who is already experiencing the symptoms, and you have to have contact with their bodily fluids. So blood, diarrhea, you know, that sort of thing. You know, so if you protect yourself from that, it doesn't spread. They also have open sores, you know, because it's a blood, you know, bleeding disease. So contact with the body can do that. The other thing we're lucky about is that there's no incubation period where they're contagious and without symptoms. So other diseases like meningitis, you know, maybe even the flu, you can be spreading it before you feel anything, before you have a temperature, before you have any signs and symptoms. So people are really sick with this when they're contagious. And I think that helps us in this country identify the cases early. So what's going on here, we have 3 confirmed cases now that became infectious while they were here. The first case was Mr. Duncan, who was a Liberian. He had been trying to get to the United States for years. His family was here. He finally got permission to come here, and a week after he's here, he comes down with Ebola. There's a lot of investigation going on in the Dallas hospital. Clearly mistakes were made, and it clearly highlights that in this situation, mistakes can be deadly and costly. He was originally sent home from the hospital with antibiotics, which caused him to expose as many as 80 people from close contacts to distant contacts, which the local health department then has to monitor, find, track, report on. When he came back into the hospital, they put him in isolation, but they allowed 70 people to treat him.
No, this is ridiculous.
That's not my definition of isolation. Some of the reports are that they then took off their gear and treated other patients. So the investigation is being conducted by CDC. It's a very serious investigation. Lawyers, unions, and everyone else is involved, and you know, I can't speak to all of it until it's finished. But we are really working hard to learn from those mistakes and make sure we don't make them here. And if you see on this list, our role locally is to be the risk communicators, so we make sure that when CDC guidelines come out on how to wear PPE, how to take it off, what your checklists are, what the case definitions are, how you do lab samples, we get that to the hospitals to the providers, to the standalone clinics, to the urgent cares. We also do the contact investigation, so if a suspect patient comes in, they'll put them in isolation. It takes 48 hours to get the labs back. If that comes back positive, we will go in and interview the patient and find close contacts. We make isolation and quarantine orders, so we'll be the ones that say your close contacts have to be in quarantine. We make sure there's supportive services. They can't stay in quarantine if they don't have food, water, other important things. The Red Cross provided that for them in Dallas. And then we conduct active surveillance to make sure no other cases are showing up. You'll hear me on the radio saying I think there's about a $10 million revenue shortage in this region for us to be able to do this with multiple cases. If 70 people actually went into his room and treated him, then the local health department has to find all of their contacts and monitor all of their contacts. And, you know, luckily, we haven't had close contact transmittal yet, and hopefully that will play out to be the case, and we can narrow that. But right now, we just don't know. So we do, you know, we will order all the way from a quarantine, you can't leave your home, to self-monitoring, taking your temperature and reporting to us daily. But we still have to monitor people and find out where they are, and can we find them if things happen. We're meeting with the FQHCs. They all have information about how to contact us 24/7. We've gone to the Walgreens and the urgent cares. You know, believe it or not, they've had people walk in the last 2 weeks and called us and said, we're concerned about this patient. We can help people walk through that. You know, Kansas had a really bad situation where someone from Somalia went to a hospital, and the hospital called the police instead of the local health department. The police went to his apartment, put up crime tape, called his boss, said he had Ebola. Somalia has 20 cases of Ebola. So, you know, we could have walked them through that and said, this is a very low probability. Keep them in isolation, we'll run the tests. So we're trying to get that message out. Your first phone call should be to the local health department. We're working with the student health centers, and we've got teams going to the hospitals, working with the hospitals, making sure we all know who each other are. We have those relationships and we're communicating. You know, we have to coordinate with fire, EMS, police, SEMA. So we have sister agencies. The other thing we're doing is really coordinating with our local partners. We put up a strike force of our local emergency response planners so they can talk. We're having conference calls with the health directors, and it involves 7 local health departments on the Missouri side and 5 on the Illinois side, because we know there's that connection across the river, to just all be on the same page. If we get a patient that you know, comes from Liberia and lives in St. Louis and goes to the hospital, lives in St. Louis County or Madison County, Illinois, and goes to the hospital in St. Louis City, we all have to be involved in that investigation. It's really bringing to light some of the geographic restraints, and we're really working through those. So that's sort of just a brief summary of where we are. I've got a good team doing this. You know, the risk of the general public and their family ever coming into contact with an Ebola patient is minuscule. The risk of public health or hospital staff doing that is higher, and the risk of my staff doing it is somewhat, you know, there will be very few of us that interview the actual infectious patient, but staff will be asked to do home monitoring. So they will have to put on the protective gear and monitor patients, but if they're home monitored, they should not have signs and symptoms. The issue is you don't have signs and symptoms, you don't have signs and symptoms, you don't until you do, right? So when did you? So we're gonna put them in protective gear. We've got training going on about how to do that. We'll have to deploy outside our communicable disease staff to others like school health. We're doing training, refresher courses with them about how to do disease investigation. Most of them have done it at some time in their career, but we're doing that kind of training. So a lot of lot of activity going on. As you know, we're funded about half from grants and the rest use tax. I can't use grants to do this. In fact, they told me I can't use our public health emergency preparedness grant to do this. I'm like, try me. I'm using that planner to plan this. Because they're in smokestacks at the federal level still. So my HIV disease investigators who are really good at this, I'm going to use them, but I'm going to have to figure out how to pay them out of use tax because I can't charge them to the HIV grant. So those kind of things just, you know, the bureaucratic things make me crazy, but we're working through them.
Us too sometimes.
I know.
Okay, so I had about 3 areas. One is on the privacy issues in terms of, you know, being outside of somebody's house and putting on protective gear. How do we handle that? I mean, it's kind of a balance between the privacy and the need to protect our people, so.
Right. One of the things that we're working on is where can we relocate people to be more private, and what they did in Dallas, the mayor actually went on TV and made a plea, and somebody donated their private residence, and now no one knows where that family's staying. So
but that's voluntary, right?
Yeah, it's voluntary, and you know, getting somebody to do that. They tried hotels, they tried apartments, they tried lots of things to move that family. That was the other really horrible part of this, and a bureaucratic thing. There's a company that will go in and clean up, and I think we use the same company here, particularly for deceased, you know, bodies, and they've been in apartments. But they had to transport the waste across state lines to Kansas. The Federal Department of Transportation wouldn't give them a permit. So that family lived in that apartment with dirty sheets and contamination for almost 3 days. So we now have an ability to get an emergency order to do, you know, to transport the waste. But, you know, there are things like that are not completely in place yet.
And you were talking about quarantine, which kind of relates to your earlier issue culturally in another country where people think of going to the hospital to die. So in the situation where folks know that they're going to be placed in quarantine, maybe their loved ones and people they know, and the word's going to go out because people are going to be questioned, da-da-da-da. So we have ways of trying to deal with that as well, because people may be reluctant to come forward if they know they're going to have to go into quarantine.
Right. There's a couple of things. One, the skill of my staff is really important, and how they talk to people and how people trust public health to take care of them, and to convince people that if you're going to live, you need to work with us because there's a 70% mortality rate. And when people come to the hospital, they come to the hospital because they're sick. So they're going to stay there. So there's voluntary home confinement, which is what we do 99% of the time. But if we have to go get a court order for quarantine, we can do that. And what we would do is just place police outside if somebody won't stay there. They kind of got excited and wanted to know about deadly force. I'm like, I don't need you to do that. What I need you to do is call me if they're leaving, follow them, tell me where they are so that we can talk them back in to quarantine. Because again, if they're in quarantine, they shouldn't be infectious. You know, so I don't need the police to ever touch an Ebola patient. Never. They don't need protective equipment. They don't need to touch them. You know, and we do this all the time. We actually have a TB case right now that's infectious heroin user, walked away from the hospital, and we're trying to find her. So it does happen. I think she walked away from the hospital because she thought she was going to be faced with a big hospital bill. In this case, you know, this is their only way to get treatment, is to stay in the hospital. So we'll see. It's a combination of skill and legal authority.
And so then lastly, in Dallas, it was my understanding that they used a reverse 911 system to try to inform people within a certain area. Do you see, is there any value to determining potential contacts in that way, or?
No. And I think that's going to go by the wayside. There is no reason to notify that nurse's entire neighborhood that she's an Ebola case. I mean, we go door to door, we talk to people, we say there's potential exposure, you know, and really try to protect the person's confidentiality. But that was not an appropriate response, I don't think. You know, they're not criminals because they have Ebola, they're sick, and they have rights. And I think Dallas and both Kansas City are going to face large penalties for violating HIPAA and be subject to civil suit.
Okay, thank you very. Any questions from the committee members? Alderwoman Flowers.
How are you tested for Ebola? Is it saliva or is it blood?
It's a blood test, and they draw 2 samples. There are about 20 labs in the country that can test for it, and CDC can test for it. So they send 2 samples at the same time to the private lab, and then CDC confirms. So it's a very reliable test.
That's not, that would happen in St. Louis, or it'd be sent to?
It would be sent to the state health lab, who has an agreement with one of those, they call them an LRN lab. I'm not sure what it stands for. And we get results back in 48 hours.
And what are the symptoms again?
Fever, diarrhea, extreme headache, and then bleeding from various orifices of your body, including your eyes, your ears, huge sores. I'm sorry, sores.
The gentleman in Dallas that died, when he first went to the hospital, they sent him home.
Right.
And they asked him, had he been out the country, and he confirmed he did. But I know they're trying to figure out what's going on, and it says in here you went to the hospitals. Is there some sort of computer entry that should be in their system so that that person is flagged, so once someone takes the assessment of their what's going on, that the doctor knows to further investigate?
Yes. And supposedly that was flagged with an exclamation point, but the doctor didn't see it or missed it. So what the hospitals are doing here is not relying just on that. And, you know, if you go into their emergency room, you'll see signs everywhere. Think Ebola, ask these questions, do this checklist, walk the file to the next level. You know, get up and go tell someone that they was from one of these 3 countries. So, you know, that was a painful lesson learned that I think our hospitals are putting controls in place for.
And what is the treatment?
The only treatment is comfort and treatment for dehydration. There is no cure, and you know, there is no real treatment. Your body just has to fight it off.
Okay. And I see here that you've met with the fire department and EMS, and you know, if a patient is transported in an ambulance and you know you don't really know yet, you just suspect, what guidelines did you give them to sanitize the ambulance to make sure there's no transfer?
We've got CDC guidelines for how to disinfect the ambulance. It would have to come offline and be disinfected, and the crew will have to be in home monitoring for 21 days and not work. So it can really impact the infrastructure of EMS.
I was thinking, I mean, I know we don't have a lot of ambulances in rotation, and I just was wondering, would that pull a crew off?
Yes.
From that?
It would pull the ambulance off for at least a couple of days. One thing on your treatment question, they are trying a new treatment where they are using blood transfusions from people who've survived, but the jury's still out on whether or not that works.
And does antibacterial spray work? Is it helpful?
Well, right now their recommendation is to use, you know, routine standard precautions, which is, you know, a hospital grade disinfectant. But theoretically, a virus you should be able to kill it by bleach, by antibacterial products, antibacterial soap. So,
I'm
you
just
know,
talking
hand
about
washing.
the average public person walking around. We just meet up at the coffee station, I don't know if Craig's been out the country, but I shake his hand.
Right.
You know, if we are taking those precautions as the public.
Yes.
If we used it.
Yes.
You know, do you
Yes.
okay, support that? And I know that our Lambert is not part of the testing, but I can only imagine this may get bigger. I don't know. I mean, from what I'm hearing, it could be. Are they ready? Do they have the temperature gauges? Or is that something that they're responsible for? Is that something you have to give them? Are they ready to test if it comes to that point?
It's a really good question. What plans we're putting in place right now with them are, their original plans were that if someone showed up in the airport with signs and symptoms, they'd send them to the hospital. If they got a report that somebody had signs and symptoms on a plane before it landed, they'd have them park the plane and have them stay there and call CDC. And I don't know about you, but I don't want locked on a plane for a few hours with somebody with Ebola. Right. So what we're putting in place now is they have a concourse that's empty, and so they would unload the plane in that concourse. We'd get the patient immediately to BJC or SLU, and then we would interview the patients, make sure we know who they are, where we can find them. There's been no transmission in air by plane to date. The only transmissions have been close contact with a really sick person. So it will give us time to find out if that person even came from one of those 3 countries and what their symptoms were and whether or not we thought they were contagious. And then you kind of go out from there. We do that with TB. If we have a TB person that's on a plane, maybe the people in front and back of them we test and monitor, but the rest of the plane is okay, and that's airborne. So all those things were kind of, I'll be honest, you can tell by when Dr. Frieden's on TV, right, from CDC, that it changes daily, and we're learning as we go, and thank goodness for them, because, they're gathering all this stuff worldwide and spitting it back out to us. So we would call them immediately and say, we've got this situation, help us through it. And we already have contacts with their international quarantine station. But
the CDC absolutely knows it's not airborne transmitted.
So far.
Yeah.
I mean, because I'm all the things that you see on TV about the outfits and how they're disinfected and how they go through this whole process, and I'm just scared that, not to put anybody on alert, but I'm just scared we don't know a lot about the disease.
Right. The way, they're watching the way the epidemic is spreading and the speed at which it spreads, and they are convinced it's not airborne.
Okay, thank you. I have no more questions.
So the purpose of the suits then are so they don't come into contact with any of the
body fluids. And then touch your eye or grab your nose or touch your mouth.
Right.
That's what happens. So it's not.
Because when people see that, their obvious thing is there must be more to this than just contact.
It's mainly to keep you from touching yourself. So it's not hazmat. You put on the mask, you put on your mask, then you put on the goggles, then you put on the head thing, then you put on the suit, you tape it everywhere. Well, you put your gloves on first and tape those, then you do the rest. You tape everywhere, you tape your legs, and then you put on booties. And you reverse that to take it off.
Okay. So I mean, for me at least, this is the best explanation I've had, because if you tell me that it's not airborne, but somebody comes in these suits with all this stuff and it looks like respirators and everything, I'm not going to buy that. But I don't know why somebody doesn't just go out there and tell them the simple fact that this is to keep the person from touching themselves and getting. I haven't heard that anywhere.
Yeah.
No,
I haven't heard that.
Frieden kind of said that, but he did it in a way that he blamed the nurse. When he said she didn't follow protocol, so she must have had some on her skin.
Well, all that does is cause the nurses to go ballistic because nobody's giving them any
who's
other
going to go in
direction.
that room now,
Yeah, the nurses' unions are very concerned about it.
Yeah, they've got a report out that's very damning of what happened. But, it's like I just did it. We touch ourselves so much
we do all
we
the time,
don't.
right.
So you take off the mask, and then, you know, and then you could do this.
Right.
Because you're sweating and your head's been itching for 2 hours. You just put it in your hair, you know? So you really have to be conscious of what you're doing. There's hospitals are doing training. They're going to come train us on this. But, you know, our staff's being trained in on Monday, and I'm telling them, I'm not asking anyone, my staff, to do anything I am not going to do myself. If we get a patient here that's confirmed, I'm going in to do the initial disease investigation, and I'm going to try to hold my staff to home confinement and not direct contact. You know, home confinement, we don't have to take their temperature. They can take it, we can look at it, you know, we just report what we're seeing. And we do that, it's called direct observed therapy with TB. You guys have heard us talk about that, where they give themselves the medicine and we just watch them take it. So it would basically be direct observed monitoring. My staff should not have to, you know, come into contact with an infectious patient. I have a couple of really good people, nurses, really qualified to do this, that will go in with me. The hospital nurses will go in with us. But, you know, we're concerned. I mean, this is a fatal disease that we've never dealt with before, and we've got to be really careful how we handle it.
Any other questions from the committee?
I have a couple of questions.
Yes, Alderwoman.
Director Walker, I'm wondering, how are we getting the seriousness into the community, most especially the ethnic community? I know I have a lot of Africans that live in my ward, and they travel a lot back and forth.
Right.
I got one lady who will probably be on her way back from Liberia soon. There's, in South County, there's a large population. I mean, how are we getting the information in of the seriousness of this? Or how are we doing that?
Yeah, I think CDC's been trying to walk the line of not panicking people, but then panicking people, you know, so that confused messages, really bad confused messages. So what I've been saying is we don't need to panic, but we need to prepare.
Okay.
And I think the more we can say that and just be honest with people, like you're saying, that there's risk, and it's from these countries. You know, I looked at the International Institute where people come from. There's about 457 people a year. Almost half of them are from Iraq. I think we've had 3 people from Liberia come through there, nobody from Guinea, and nobody from Sierra Leone. So it's the casual traveler, you know, like you said, that they live here, they travel back and forth.
They do business back and forth.
They do business back and forth. Right. They're going over to help, you know, and coming back. They're students that are here. So that's why we're coordinating with the student health centers.
Okay.
And yeah, there's, you know, I never think it's okay to scare people to get what you want, you know. But we need to be honest with people that there are risks, but that it's very, very low. And just track people, you know, and the people that are going back and forth need to be willing to come forward and tell us if they've got signs and symptoms. I think they will, because it's such a scary disease.
Then my next question is, if you pay attention to the outcomes that we've seen, is this a disease that affects the one ethnic group more severe than another? Because I have to believe it has to do something, it's something with the immune systems, that one is stronger than the other and people are able to survive. If there's not a medicine or a vaccine that's going to cure you or make you, you know, tolerable, then how are we going to be able to help people?
I think that's a really good question, and I think no one knows the answer to it. NIH was beginning to develop a vaccine about 5 years ago, and their funding got cut. And I think that's the kind of research that goes on when you develop a vaccine, because you test it on different populations, ethnic populations, and ages, and everything else to see its efficacy. And that work has not been done yet. And so all we have right now is that African population, you know, which is ethnically similar, to compare it to. So I can't answer that question if it's, you know, you could assume that if you're poor and hungry and living in a refugee camp and your immune systems are compromised like they are, the death rate's going to be higher.
Right.
But
then we saw the gentleman who came here.
And did not live. Yeah, that's.
And he didn't live, and the others did.
I was going to say, you know, that it could be he got into treatment late, you know, because they sent him home and he came back. It could be ethnic. It could be something else in his background. It could be this particular strain that he caught. And
also, there's strains as well?
There are different strains, yes.
Oh, my goodness, okay.
Yes. Yeah,
Picked up on that.
The few cases in Somalia are a different strain.
Okay.
So a lot of unknowns.
Mm-hmm. Thank you.
Any other questions from the committee? Alderman Arnowitz.
Director, and I guess, you know, like you said, there's a lot of volunteers that go out of country to help.
Right.
You know, so I guess before they leave to come back to the United States, do they probably, I guess, test everyone and for that 48 hours before, I guess, they allow them to come back to make sure they haven't contracted?
They don't do a blood test.
Okay.
Everybody who boards a plane in one of those 3 countries gets their temperature taken, and when they fly into these 5 airports that have the direct flights, they get their temperature taken again. The problem with travel is this. I'm a U.S. citizen. I went over there to help. I leave Liberia and I go to Paris, and I decide to stay 3 days with my friends, so I don't have a connecting flight. I book a new flight. I fly into Dulles. It looks like I came from Paris on the manifest.
Right.
If you look at my passport, you'd know, but, you know, who's really looking, you know? Maybe they are now. I stay a few days in Virginia with friends. I book a new flight from Dulles to St. Louis. Why would you even look at my passport? I'm a U.S. citizen, and I flew in from Dulles.
Right.
So the air travel's really, really, really difficult to track. CDC's some of the smartest people I know are trying to figure that out. And it's really hard to do unless, and we don't want to shut the borders, because if this turns into 10,000 cases a week, 1 million cases in December, it will be 3 million in March. It'll be 6 million in June. I mean, it is spreading exponentially. You will see major collapse of economic security in Africa. Then what? Then what? We pull out troops, we close our embassies, we don't have access to oil. What? You know, we've got to stop it there. So you can't shut down travel. You can't.
Right.
We've got to get in there and out of there to help.
And I mean, I agree with you 100%. And like you say,
that's everybody's like easy. I wasn't saying you were saying that, but I hear that's everybody's easy solution. We'll just close the borders. Not going to work. It's not going to work.
No. And you're right. And, you know, we don't want to scare people, but we got to make people aware of what's going on. Mm-hmm. And if you think you got symptoms right away, you need to, you know, yes. I guess you want them to call the health department instead of going to a hospital, I guess.
Well, I'd want them to go to the hospital immediately, but share their, you know, their information, right. and then the hospitals call us.
All right. Well, you know what? And I appreciate everything you do, because you put a lot of time and research and stuff, and I really admire that. So I want to thank you.
I've got an amazing team. I mean, we had a meeting, we had a planning meeting. We said, what do we need to do to prepare? It was before. You know, it was 2 days after the Dallas case, and they did this. You know, Commissioner Moore leads this. She's out of town today, or she'd be here. They know what they're doing. They really do. I mean, I really trust my staff to know how to do this, and they're awesome.
Any other questions from the committee?
Mr. Chairman, I have one more.
Another one? Go ahead.
This generated, from my understanding, from eating wild animal in the bush? Where does generate
fruit bats.
Fruit bats?
It's endemic in fruit bats, and they make it in a stew. And we've had 26 Ebola outbreaks, but this one was started in, I believe, Guinea, in a village, and of where there's unrest, and they didn't pay attention to it. And then as that civil unrest happened, there were maybe a couple of dozen cases. They left to Liberia, you know, to the refugee camp, and took it with them. But yeah, that's the theory, is that it's endemic in fruit bats, and so I don't think cooking and eating it, but handling it, you gotta.
Fruit bags?
Bats.
Bats.
Oh, fruit bats.
Yeah.
Oh, okay, I got
Which
you.
we don't have, thank you.
Right, okay. And,
Thank you
and
very
again,
much.
it's something that it has to get in our mouth or in a cut
Yes.
in order for us to get it.
Yeah, in your eye, your eye.
Get it in some
yeah.
sort of, kind of like a HIV.
Well, we were talking about that
Has
earlier,
to
yeah.
be able
Yeah.
to get into your bloodstream.
Right, and to
Okay.
kind of put it in perspective, West Nile is endemic in birds and mosquitoes in this region. We've had 3 human West Nile cases since I've been here. So, when it's bloodborne and it's not airborne, it's hard to get. So the odds, of the general public in this country, seeing the kind of outbreak we're having over there, unless it gets total chaos and, the nightmare scenario, is really low. And, I think we need to keep saying that. It's really low, but if you've traveled to one of those countries, you need to have a high level of concern. And if you have a fever or feel bad at all, get somewhere and let us test you.
All right, thank you.
Any other questions? Thank you very much.
Okay,
We'll stay
thank you.
tuned, and I'm sure
Yeah.
there's more to come.
I will keep you informed.
Carl Filler has a great presentation on our HEAL partnership program. Okay.
Good morning. Thank you for giving us the opportunity to speak to you all. Unfortunately, the other members of the partnership couldn't be here this morning, so I'll be speaking in their stead. So the Health Eating Active Living Partnership was something put together earlier this year by the Department of Health in response to some resident and community partner concerns raised during our community health assessment and community health improvement plan. They identified various health outcomes and concerns they had in their communities and neighborhoods, particularly diabetes, hypertension, and cancer. And all of these diseases and health statuses are caused, at least in part, by obesity and weight status. We also have the Mayor's Sustainability Action Agenda, which directed us to reduce obesity by 5%. And the previous partnership in the city, the Healthy Youth Partnership, dissolved this year. So there's no coordinated effort until earlier this year to address obesity. So there's a couple of slides here. I don't need to go through all this since you've probably seen this all several times, but we do have relatively high obesity rates here in the city. We have highest rates of heart disease mortality and diabetes compared to the state in the United States. We also have a lot of health disparities, so parts of our communities suffer disproportionately from the diabetes and hypertension and other diseases that come from obesity. And we have some maps here that you can look at. The darker colors are the highest mortality rates, and this is sort of the worst case scenario where someone actually dies from diabetes or heart disease mortality. So we looked at this and we convened a group in early February. This was sort of a wide net that came out of our obesity plan, where identified partners who've been working in the community for many, many years to increase healthy lifestyles through diet, nutrition, physical activity, and all other sorts of things. And we created this partnership, which we call the HEAL Partnership. Again, Healthy Eating, Active Living, and we formed it into different work groups to focus on specific components. So active living is basically physical activity in sort of the built environment, which is, sidewalks, roads, Metrolink, parks, that sort of thing. Healthy eating, thinking about access to food, thinking about understanding about food. What do I eat? How do I eat? How should I be teaching my children, my family? What should I be asking for at school? Healthcare, which is about accessing healthcare for once you've developed a chronic disease, you need to manage that disease. So understanding how you can get access to healthcare services and chronic disease management is extremely important. Social marketing is just getting the word out to folks, making sure that everyone's connected to the resources they need to be. Then finally, evaluation and data is our sort of academic arm, and these are our sort of professors and other folks who are really interested in making sure that what we're doing is working and that we have the resources and data that we need. The next page, where it says organizational membership, this is just a really quick list of a lot of the organizations that are a part. This is probably not exhaustive. It changes kind of month to month. Our work groups meet monthly, and the full partnership comes together quarterly. And the number of partners kind of changes based on who's around at the time. But these are the partners who have been there pretty much since day one and have been very active. So we just want to thank them for helping us without being compensated in any way. They do this work because it's something they're passionate about, because they're already working on it, and they want to make sure that they're effective in what they do. So early on in our conversation with our partnership, we identified that the city's a big place, may not be as big as other places, but it is large and it's sort of daunting to take on at once. So we thought it would be helpful to start by narrowing down on some pilot communities. Communities that we started by looking at were those with the highest area of need. So a lot of the community has many, many needs, but we looked at two things, diabetes and heart disease, which are the biggest connected to obesity. Cancer also has a high rate, particularly colorectal and breast cancer, but heart disease and diabetes really have a very close relationship with weight status. So these 4 zip codes, 113, 106, 111, and 101, were all identified as having the highest, or we sort of added some quick math, but if it was the 2 highest rates, these zip codes came to the top. There's a little asterisk next to 63101, not because it's not an area of need, but because it has a very small population, and it was also connected to 63106, at least geographically. So we thought we would focus on 113, 106, and 111. Yes.
I just want to interject because normally my recollection is we usually see 63107 and 63118, and those are not.
Those have, yeah, so there are health concerns in those neighborhoods that are not necessarily related to obesity, but they are related to many other health outcomes. So HIV, AIDS, sexually transmitted infections, infant mortality. There's many, many health concerns our residents are focusing on, and so these 63107 and 63118 come to the top in other metrics.
But not here.
But not in heart disease and diabetes. So yes, if you are living there, this is maybe not worry as much about this, but there are still concerns, and the health department is working on other infant mortality issues in those communities. So we went through a process over probably about 4 or 5 months to dive down into these zip codes. So zip codes are kind of an abstract for many of our residents and for our partner organizations. People in the city obviously think about neighborhoods. When you ask you where you're from, you don't say I'm from 118, you say I'm from Dutchtown, I'm from the Greaterville. So we looked at it that way and tried to get down really local in that respect. Unfortunately, we don't have a lot of good health data at that level. We're lucky even to have the zip code data we have right now. So we had to go by some other metrics. So we identified these zip codes have need. So what can we build on that's already there? So we thought about neighborhood assets. And these can be from individuals who we know are active in the community, who can be real champions for us. We also thought about parks. We thought about churches. We thought about community centers. We thought about grocery stores and all sorts of things like that. And so we had these sort of long engaged discussions in our work groups and came together with a couple maps and then these metrics, which we called neighborhood selection. And we used a couple different items so that we could, it's not a perfect system, but at least we had some kind of research and intention behind what we were doing. We weren't just selecting communities at random. So the communities that we ended up selecting based on these criteria for both active living and healthy eating were based on these metrics of, for active living, the first one, local government support, neighborhood group activity, park score, CDC, Community Development Corporation support, and then we created this metrics. And the 4 communities that came to the top, or neighborhoods, were the Greaterville, Jeff Vanderloo, Dutchtown, and Carondelet. This is not to say that the other neighborhoods aren't also in need, but we want to start somewhere, pilot some activities, and then start ramping them up once we knew how to do them in other communities. Likewise, with healthy eating, it was similar, but instead of parks, they talked about grocery stores and vehicle access. So community stores that didn't have grocery stores in them or didn't have access to vehicles, we have some data around that. We're able to look at and identify then those communities that weren't able to access healthy food. And so we use that and we identified they are similar but not exactly the same. Greaterville, Academy, Dutchtown, and Mount Pleasant. So Greaterville and Dutchtown will be focused on for both of those groups, and then Academy, Mount Pleasant, Carondelet, and Jeff Vanderloo will be a little bit different. But they're all sort of in the same geographic area, so we're hopeful that there'll be some overlap there. And then finally, we have our work plan, and I just kind of put it in the highest level. So we have these tactics, and underneath the tactics, we have activities. Under activities, we have specific items that individuals will be working on. But we wanted to give people kind of a snapshot of what we were doing. So for the active living work plan, there's these 5 tactics. Safety is really one of the big things. We did an interview with all of the neighborhood stabilization officers, or the neighborhood improvement specialists, I guess they are now, and spoke to them and what they'd been seeing in the community. And they said, you know, the biggest barriers to physical activity in their neighborhoods were safety. People didn't want to go out there and walk because either the sidewalks weren't in good condition, the streets weren't safe, the parks weren't safe, or they felt that people were out there that made them uncomfortable, whatever that might have meant. We didn't dive into that too deeply yet, but one of the things that was brought up was that people like to walk around their communities. They like to form walking groups, and the walking groups maybe not in and of themselves will be enough physical activity to lose weight, although it may. We've had some NISs, I think actually yours, Alderman Schmid, had some success with that. But it puts eyes on the street. It builds a sense of community to have people out there. So we're going to see what we can do in these communities to build and support walking groups, or what other sort of things the community want to improve safety. We're also exploring some opportunities to do some worksite wellness programs, active living programs, make sure that they're brought to communities that need them, and things along those lines. With healthy eating, what their folks are going to do in that is spend a lot of time talking to residents, asking what they want. We've tried things in the past that have had sort of different levels of success. Oftentimes we've brought interventions and resources to community and they say that's not what they want, or it's not meeting them 100% where they need to be. So we're going to go the other way this time and go to them first and ask them, what do you want? You know, understanding you need to eat healthier, or you need access to healthier foods. What can we do to make that happen? Is it just putting a banana stand in the corner store? Is that enough? Or do you need something else there to make that successful? So we'll be exploring that with sort of an intensive community conversations that our groups like Operation Food Search, the food banks, and other folks will be doing in the community. Healthcare Access Work Plan, we're really looking at community health workers. So for those who are not familiar with what that is, it's training community residents to serve as access points to healthcare. So people who are trusted in the community can help folks manage their chronic diseases, help them walk through enrolling in health insurance, identifying when they need to go to healthcare, and then potentially even delivering services. Other states allow for Medicaid reimbursement for community health workers. Missouri does not allow that, but it's something on their radar. So if we can set up an infrastructure and then tap into that, we can provide jobs, education, and healthcare to our community residents. So I think that really helps out on many different levels, and we're very excited about that. And as always, trying to expand Medicaid, but that's a big item that's a little bit outside our control, but we're doing what we can in that area. Data and evaluation, we're trying to get access to more BMI data. We don't have very good data in the federal government's last round of the behavioral risk factor surveillance system, where we get most of our obesity data, will not include St. Louis City because they didn't ask enough people, so the sample size is too small. So we're working with the state to try to fix that next round, but for now we're trying a couple different options. We're speaking to the Department of Motor Vehicles to get addresses, weight, and height from everyone's licenses. Washington State did this, and they were able to map BMI for everyone in the entire state. We'd like to start with the city and then see where we can go from there, and we've been working on that. Some of the hospitals are interested in sharing their data. The school system has some data for all their 5th graders, although I guess they started 3 years ago, so some of them are 7th graders now. So we can look at childhood obesity, which is another important thing, because once you set those patterns early in life, unfortunately it's hard to change. And we're also doing some grants and other studies with our academic partners to make sure that we're sort of making sure that whatever we do works, we can show it works, and then we can turn that into programs in the future and get some funding from the state or the federal government. And then our social marketing plan is to support the interventions we select and make sure, and we're working potentially with St. Louis Public Radio as they have a project with the Missouri Foundation for Health to identify sort of the decision makers in every community, be it a coach, a barbershop owner, a grandmother, anyone in a neighborhood people kind of trust and look to for information, and help work with those individuals to disseminate messages throughout the community.
So your social marketing is not virtual, not virtual,
a lot
just
of it,
virtual.
Yeah, we will do some Facebook and Twitter and all that good stuff, but we also do face-to-face because not everyone has a smartphone.
Good.
And last, I did want to say that this is the last page is our work group chairs. So Matt Alexander's from the American Heart Association and is leading our social marketing group. Leslie Birch and Kara Lubischer are from Operation Food Search and University of Missouri Extension, and both are leading our healthy eating work group. Rhonda Smythe is from TrailNet and is leading up our active living work group. And then Cassandra Arroyo Johnson is a faculty member at WashU and is leading up our healthcare data and evaluation group, as well as the chair of the entire partnership. And everyone, I will say, has put in hundreds of hours of time over this year. We have paid them nothing for this. So this is a really community invested partnership. And we're really excited, and we think we're in it for the long haul, but we hope to see some results over the next year or so. But we want to update everyone, so any questions, or if you're ever interested in coming to any of the partnership meetings, please do let us know. Happy to extend that invitation. We move them around the city so that we can give people pictures of different communities, but we appreciate the chance you gave us to talk today.
You require us to walk there or bike there to the meeting?
If you want to, we bike and walk along with you, but if you want to drive or take the bus, that's fine too.
Okay, that's fine. Are there any questions from the committee? Okay.
I have a couple.
Okay, go ahead. We'll just, whenever the tape ends, that's fine.
Oh, we're fine with that.
Go ahead.
I wanted to share a couple of things. Well, first let me ask the question why, you know, I'm okay with WashU and all of that, but I think there's some more significant entities that should be partners here. Let me put it gently like that, okay? And I say that because they're closer to the communities, probably have better experience and information, and can help you get further. And so I'm going to give you an example. The Harris Stowe University has been working in a collaborative mode with the African American Caucus of the Board of Aldermen. We've done significant research in health disparities. We have done a lot of committee work on how to go into various parts, and actually we've identified some of the same areas that you've identified.
Great.
But aside from that, we have Dr. Mark Abbott there. His students in his urban affairs department, several of them are focusing on the very same topics that are listed here. They've done a lot of research. They've developed some marketing tools, videos and all of that, and done extensive research for grants. And so I thought that it might be good for you to bring them in as part of the partnership.
Yeah, we'd love to.
Because that's some more, it gives you more strength to get some things accomplished. And so I know that they've looked in the Jeff Vanderloo neighborhood extensively, visited the schools and neighborhood groups and those kinds of things, and it just might be helpful for you.
Well, on November 1, Carl will be at Harris Stowe State University as part of the SLACO Regional Neighborhood Conference, and I know Mark Abbott will be there as well, but prior to that, I'm sure he'll have an opportunity.
Yeah, I think you'll find a lot of good information, and you'll find the university itself is committed to working in neighborhoods. And I've worked with Dr. Abbott probably the last 15 years on various initiatives, and they've assisted us in getting a lot of different grants, not only for community building, but for social work and other things. So I think it might be good. And I know the last meeting we had, I was extremely impressed with what they had done thus far and the next steps that we should take. And I think what you've done here is impressive as well. I think the two should really come together.
Yeah, I'll reach out to him later this week. I appreciate it.
All
I might
right.
mention your name if that's okay.
Okay, that's okay.
Thank you.
All right.
Are there other questions from the committee? If not, I don't know that we technically need a motion to adjourn, but I'll entertain one.
You could just say it.
We're adjourned. I make a motion to adjourn. It's been seconded. Any opposed? We're adjourned. Thank you so much.